want to just throw that. And as you can see, we are recording, and I'll get to that in a minute. So the findings on the salary surveys mirror the national data. Our Gender Pay Equity Subcommittee was formed in response to this unjust situation. We have a busy schedule, but I want to share a bit about our format before we get started. We anticipate taking 1 or 2 questions after each speaker's presentation. Please raise your hand or put your question in the chat. We've saved 15 to 20 minutes at the end for additional questions. The meeting is being recorded. We anticipate discontinuing the recording after the last speaker's presentation. This will allow audience members to ask more questions, including those they may not wish to have recorded. That being said, we genuinely hope to make this a dialogue. I hope we will come away informed and empowered, with eyes wide open, and with ideas for specific actions to be taken. And finally, I hope we leave with a sense of hope for a more equitable and just future. And now I will introduce our first speaker. Dr. Robin Motter-Mast is a GBMC, Greater Baltimore Medical Center, employed family medicine physician. She's Chief of Staff and Medical Director of Care Transformation, which is dedicated to advancing patient care, clinical innovation, advocacy, and mentoring. She currently serves on the MedChi Board of Directors and as chair of the Committee on Medical Economics. She is also president of Baltimore County Medical Association and vice president of the Maryland Academy of Family Physicians. Thank you, Dr. Motter-Mast. We'll let you get started.
Thank you. Good evening, everyone. It is great to see you tonight. And I'm going to spend some time talking about and laying the groundwork for the upcoming presenters. And we're going to talk about physician compensation nationally and in Maryland. So objective of the next few minutes, we will review national and Maryland specific data on physician gender pay gaps, highlight contributing factors and trends, and present actionable recommendations to close the gap. So Maryland physicians are the lowest paid in the country. So we vie for that spot year after year. We're usually either 49 or 50, and it's a problem. There's no specialty in Maryland that is paid at more than the 50th percentile nationally. And primary care specialties are paid the lowest of everyone nationally and in Maryland. The lowest average compensation by metro is shown on this slide. And here we have received the prize again. We're top ranked, #1, lowest. Often Washington, D.C. gets to have the honor, but at this year in 2024, it was Maryland. Other things that we want to consider are the cost of living in Maryland. And Maryland is ranked 9th in the highest cost of living in the country. The surrounding states of Virginia, Delaware, Pennsylvania are all ranked lower or less expensive than Maryland. And Washington, D.C. is ranked higher. Our population and doctors are aging. By 2036, the U.S. population is projected to grow by 8.4%. The population 65 and older is projected to grow by 34%, with an average increase of 54.7% in the size of the population aged 75 and older. We have a nice tsunami coming at us. Older patients need more health care and access to more physicians. A large portion of the physician workforce is nearing the traditional retirement age. 20% of the clinical physician workforce are 65 or older. 22% of the clinical physician workforce are ages 55 to 64. And a significant number of physicians will retire in the next decade. If you do the math, 42% of us are 55 and older. Things that we want to consider. Healthcare employers are facing increased challenges in attracting and retaining top talent. Healthcare professionals' preferences for work locations and specialties are shifting making it more difficult for healthcare organizations to retain providers and physicians. And there is a growing physician shortage and higher rates of work-related burnout. Let's talk about burnout for a second. The rates of burnout among female physicians have been a significant concern in the medical profession. Recent studies have shown that while the overall burnout rate among physicians has decreased, female physicians continue to experience greater rates of burnout symptoms compared to their male counterparts. These statistics highlight the persistent challenges faced by female physicians in the medical fields, particularly in terms of workload, workplace culture, and work-life balance pressures. Addressing these issues is critical for improving physician well-being and ensuring high-quality patient care and keeping women in the workforce. We all know about the challenges to our healthcare system, but I thought I would take a second here and highlight a few of them for us. 30% of Americans don't have a primary care provider due to a shortage of providers. Maryland has the longest ER wait times in the country, and there has been failure of our state and federal government agencies to intercede adequately. We all are, unfortunately, really living those statements right now. And the physician supply lags patient demand nationally and across Maryland. So the U.S. is projected to have 120,000 too few doctors nationally. Maryland is projected to be short 1,052 doctors by 2030. The aging workforce is most prevalent in the capital region and among surgical specialties. The last bar shows how we ranked against other states when we look at the doctor to patient ratio. What are the potential impacts of this physician shortage on our patient access? Well, our wait times are going to get longer. There will be diminished access to healthcare services. We're going to have worsening healthcare disparities, especially if we have women leaving the workforce, and delayed treatment of medical interventions. Look at the national data that we have. It shows that male physicians earn 25 to 30% more than female physicians, and that equates to a lifetime earnings gap of $2 to $4 million. We know that specialty hours and parental leave do explain it, but they only partially explain this gap that we see. And we also know pay transparency and negotiation impact compensation. If you look at median compensation for male physicians, it's around $350,000 to $370,000, and for female physicians, it was $270,000 to $295,000, depending on your specialty and your region. So let's start talking about Maryland. We heard that Maryland MedChi did a study. It was a small study that was done in 2024 in collaboration with BRG. And it did show that average salaries for physicians went up, which is great, went up 29% since 2021. But it also determined or showed that there is still a significant gender pay gap. You see that here on the slide, where males are earning 45% more on average than females. The study also showed some significant issues with racial disparities and the way physicians are paid. Here you see the magnitude of the gender pay gap in Maryland when it looks at specialties. So women physicians in Maryland earn approximately 10 to 20% less than their male counterparts, even after adjusting for specialty, experience, and hours worked. The gap varies by specialty, with larger disparities in surgical and procedural specialties and smaller gaps in primary care and cognitive specialties. There are factors that contribute to this gender pay gap. So a few of those I have listed on the slides. We'll discuss productivity-based compensation models were identified as a contributing factor. Women physicians often spend more time per patient reducing visit volumes and earning under and their earnings under productivity-based models. Other factors are procedure volume and complexity. We know that women physicians perform fewer high RVU procedures, resulting in lower reimbursement. Conversely, though, I want us to remember that women often have higher quality scores and higher patient satisfaction scores than their male counterparts. Other factors are industry payments. When we talk about industry payments, we're talking about things like pharmaceuticals and medical device sales. For some reason, men seem to have more of a corner on that market, and we don't exactly understand, but there are some things pointing to the reasons for that, but that definitely needs to be studied more because it does contribute to this pay gap.
No, click okay.
Please mute yourself. I would appreciate it. Thank you.
I can't lose. I'm not losing.
Other factors to contribute are practice composition. So predominantly male practices show larger gender income gaps. And then we need to think about leadership and academic roles. Women are underrepresented in these leadership positions, and that it does impact their earnings. We also know that parental leave does impact our salaries, but it doesn't always make sense. So here's some information about female physicians who took leave earned approximately $264,000 on average. Then if you compare this to male physicians who also took leave, you see the male salary was much higher. And then if we compare that to female physicians who never took leave compared to the salaries of the males who took leave, it's still less. So we know that parental leave has a long-term negative impact on female compensation. What's the impact of the gender pay gap overall? Things to think about. Well, lifetime earnings, we already mentioned this, but it's really important to think about. Physicians lose 2 to 4 million over a 30 to 35 year career. Career advancement, if we don't advance in our careers, we're going to have lower earnings. It hinders our advancement and our leadership opportunities. We do want to discuss workforce diversity. We know it's really important, not only for our workforce, but for the patients that we serve. We want to have, it shows persistent disparities, which can threaten diversity and equity in medicine. And then increased frustration and increased chance of leaving the profession early for females. We're already burning out, and then we hear this about our salaries, and it can be really a point of despair for us. So there's some recent trends and initiatives in Maryland. We've seen some modest progress in narrowing the gender pay gap with slight reductions in some specialties. The initiatives that we found through the study were related to salary transparency, some places having mandatory disclosure to reduce disparities. Equitable scheduling was something that was worked on, reducing unpaid labor and improving a work-life balance, and value-based compensation, recognizing time-sensitive, high-quality care. A couple of slides ago, we talked about the increase in RVUs for our male counterparts. But we have to remember, we are decreasing utilization, and the quality for our patients and the patient satisfaction are actually up. And the good news is with value-based reimbursement, some of those things are starting to be recognized and paid for. So those are things that we need to highlight for ourselves. We know that pay transparency is linked to higher compensation. So one of the things I want to encourage you to do is make sure that when you go into those conversations that you ask what the compensation range is. You want to know what it is before you go in. If you know before you go in, there's a better chance that you're actually going to end up with a higher compensation rate. We do know that most compensation structures are salary and productivity bonuses. So something else to think about as a woman when you're thinking around how you want to negotiate your contract, where you're actually going to be able to deliver on some increased value for your employer. And then lastly, I want to urge people to use legal assistance in negotiation. And we do have a lawyer here this evening with us. We're really excited for him to share some strategies with us. But you can see there was a really significant difference if you use legal help versus if you did not. We need some policy changes. So things like mandatory salary audits and regular audits to identify and correct disparities, transparent compensation policies, which are clear, equitable policies across all specialties. And we need support for women in leadership, mentorship, and sponsorship programs. We also should be encouraging bias training. We know that there's some implicit bias for administrators, those people doing the hiring. The gender pay gap in physician compensation in Maryland remains a persistent issue driven by structural and systemic factors. Targeted interventions and policy reforms are essential to achieve gender equity in physician compensation. So here are some additional recommendations to close the gap. Implement standardized pay structures. So you want to know what the pay range is before you go in. We just talked about that. Conduct annual compensation analysis by role and market benchmarks regularly and ask to see the information. Provide salary levels, ranges, and job postings and during hiring. Annual employee surveys on compensation fairness. Those could be undertaken to see how we're doing. Are we meeting the mark? Solicit allied health staff input on engagement and collaboration. We also know that the gap for females in pay isn't just in medicine, it's across the board. In fact, there was an article in the New York Times last week, I think it talked about an 18-cent on the dollar reduction that women get paid across the board. So it's not just about us. Let's get everybody involved. We can compare performance on outcomes, not just on volumes, and evaluate providers on patient-oriented results. Remind your employer that you get paid for the patient satisfaction and you get paid for the quality as well as the RVU productivity part. Use quality measures for performance evaluation and insurance contracts that'll help your payer to get more money. So that completes my remarks for this evening. And I just want to remind you as a woman, it's never overreacting to ask for what you want and need. Thank you very much. I appreciate your time, and we'll take questions. Anybody has a question now, or you can hold it to the end and put it in the chat. Thank you.
Well, thank you so much, Dr. Modermast. Excellent presentation, and I think we'll keep moving. Next up, we have Dr. Sarah Kate Rappaport. I think her presentation is going to dovetail perfectly with yours, Dr. Modermast. Dr. Rappaport is an otolaryngology head and neck surgeon in Washington, D.C. at the D.C. Veterans Affairs Medical Center and an assistant professor at Georgetown University. Her research focuses on gender pay disparity in medicine, aiming to identify and address systemic factors contributing to inequity. She brings both clinical expertise and scholarly insight to our meeting tonight and working on closing the gender pay gap. So thank you, Dr. Rappaport.
Having some technical difficulties. I tried to share my screen and somehow it's only sharing part of my screen. Can you guys hear me at least?
Yes, we can hear you.
Yep.
Okay. Is anyone with more, or maybe I'll stop sharing and try again. My apologies, guys. Trying to find the share screen option. Here it is. Does anyone, I'm not used to sharing my screen. I keep clicking sharing my screen and it's just showing me a green box. Here, maybe I'll just move it like this. It covers mine. I don't know if this is how it's supposed to work.
There we go. Now you're up.
All right. Well, it's really a pleasure to be here tonight. Thank you so much for having me. Over the past few years, I've been performing research that focuses on the issue of gender pay disparity in medicine. And in my talk today, I want to go from kind of the macro level that Dr. Mattermas was talking about, sort of looking at things a little bit more granularly. I'd want to use my specialty of otolaryngology, head and neck surgery, or ENT, as a case study to illustrate how the gender pay disparity exists in medicine. I want to review some national trends that reflect the data. I want to include new data from the 2025 American Academy of Otolaryngology's workforce report that just came out last month, which, in the same way that Dr. Mattermas was talking about making sure that we're reporting national level data, I think it's helpful to kind of look at our specialty and use that as a way to understand what is likely reflected in the other specialties that are represented here today in the audience and just generally in medicine. I want to also share an analysis of CMS reimbursement rates and then discuss what my current research is uncovering about why these disparities persist and what we can do to address them. So we know from numerous reports, from what we were just talking about, that gender-based pay differences exist across every medical specialty. And otolaryngology stands out as one of the specialties with the largest gender pay gap. On some of the slides you saw, orthopedic surgery was at 20%. Otolaryngology reliably has a 25% gender pay gap, which is the highest of any surgical subspecialty. Addressing this inequity isn't just about fairness, although that alone is a reason to care. Like Dr. Mattermas said, it affects workplace stability, it affects physician satisfaction, equity and leadership opportunities. And inequity shapes recruitment, it shapes retention, it shapes morale. So if we're serious about cultivating a strong, expanding, and diverse workforce, pay equity has to be part of that conversation. And I imagine that no one in this audience really needs convincing of that, but sometimes it's really helpful as someone who already feels strongly about something to have the language and to understand why it is that you're advocating for what you know you shouldn't have to advocate for. And so if we want to attract and retain a diverse, talented clinical workforce, we have to ensure equal opportunity and advancement for compensation as well. I had always imagined that productivity-based payment structures in medicine would be the great equalizer in salaries between male and female physicians. And when it became evident that this finding was not reflected in physician reimbursement payments, it was easy to initially assume that the pay gap simply reflected a trend in actual productivity. Perhaps women work fewer hours, perhaps they see fewer patients. But after controlling for clinical hours, for RVUs, and even practice types, so private practice, academic, community-based hospitalists, a consistent gap remains. So this tells us the disparity is not purely productivity-based, but it's influenced by multiple layers: compensation models, call pay policies, sometimes unconscious bias in negotiation or advancement. And this can feel really disheartening, but I actually think that looking at the data is really helpful. So I want to do that a little bit together. The first comprehensive look at gender-based pay disparity in otolaryngology, which was one of the first publications actually in this arena, was published in JAMA. It came from Stacey Gray and her colleagues in 2020 out of Harvard University, and they analyzed national CMS data over 1 year, 2016 to 2017, which compared reimbursement patterns between male and female otolaryngologists. And what they found was striking. They found that women received only 75 to 80% of the total reimbursements that men did. And this difference remained after adjusting for productivity measures like work RVUs and number of patient encounters. And CMS reimbursement isn't supposed to vary based on gender. It's not supposed to vary based on anything other than the number of RVU for what has actually been performed. So this finding was a real head scratcher and initially seems to make no sense. But this was the first time a specialty specific national scale study quantified the gap in our field when it came to reimbursement payments. And it provided a clear data-driven baseline showing that the disparity is real, it's measurable, and it's not explained by differences in workload. And their analysis really set the stage for subsequent work, including my own, to expand on these findings and explore what underlying factors might be driving this difference. Around the same time that Stacey Gray published her article, this article, Gender Differences in Medicare Payments Among Cardiologists, also came out. They looked at the data for 2016 to 2017 for cardiologists, and they found the same trend. And these papers were published, just months apart from one another. And slowly, The results from Gray's group were echoed in research published over the last several years in various journals, not just JAMA, but other specialty-specific journals, demonstrating the same trend that gender pay disparity between male and female physicians in CMS payments specifically persisted despite controlling for all variables that the researchers were able to control for. Building on Gray's work, I led a research team at Georgetown that analyzed CMS data from 2013 to 2018, covering over 43,000 otolaryngologists. And we found that female otolaryngologists earned 75 to 81% of the amount that male otolaryngologists earned in their CMS reimbursements consistently every year. So this not only mirrored Dr. Gray's findings, but it showed that historically this trend was persistent, that her finding from 2016 wasn't an aberrant finding. And what we found was that the annual median total reimbursements were $114,000 for men versus $73,000 for women, which is a 36% difference. In our analysis, we broke otolaryngologists into 8 productivity octiles based on their Medicare work RVUs from lowest productivity to highest. And you can see on this bar graph that women earned less than men in every octile, from the lowest to the highest productivity groups. Men are the blue bars, women are the pink bars. And even after controlling for productivity, so the degree of productivity is the same measured for men and women within each octile. So even when we controlled for productivity, women earned less. And this trend really revealed that a gender pay disparity persisted even when we accounted for productivity with a more fine-grained resolution. Over time, this pay disparity was not an isolated finding in that 1 year that Dr. Gray had analyzed. And when the data is organized in this way, where we control for productivity, the takeaway seems really simple, that the gap is not limited to any single cohort, any single group of productive or non-productive men versus women, but it's a consistent pattern across the entire workforce over time. Stated differently, even when we broke down all the surgeons into 8 groups from low to high productivity physicians so that men and women were matched for level of productivity, men out-earned women at every level. And it's concerning that even when we controlled for productivity, that this gap remained, meaning that women were reimbursed less for similar levels of clinical work. But within this project, we started to also look at specific CPT codes, namely the most common outpatient procedure codes that we could, that were reported in the CMS database. And we began to observe small patterns. We also found that men submitted more unique billing codes and total charges than women. And this data also begins to suggest that the disparity can't fully be explained by differences in clinical volume or billing behavior, but that there's something deeper driving the inequity. Perhaps it's the types of cases that are being performed, the referral patterns for how many procedures you're getting versus just an E&M encounter, or even institutional biases that are somehow affecting the way that your clinic is structured. Recently, the American Academy of Otolaryngology Head and Neck Surgery published a workforce report in 2025 that provides us with the most current snapshot of compensation patterns across our specialty. And I imagine that this kind of workforce report likely exists for most, if not all, of our specialties. We just have to know to look for it. But these 2 figures that I excerpted from the workforce report, 2.1 is the top and 2.11 is the bottom, show the median clinical income by sex and age, including within academic settings. And so even when we look at reimbursement data in the workforce from this perspective, the data are clear. There are income differences that persist across every decade of practice, and they persist even in academic practice, where salary structures are theoretically more standardized. So to me, these findings reinforce that structural inequities remain embedded in how we value physicians' work. This report also published data that demonstrates that the median clinical income for women in otolaryngology is about $350,000 to $375,000 compared to $475,000 to $500,000 for men, which was something that Dr. Madermast also discussed and shared in her presentation. And I was, you don't want to see these numbers, but it was really helpful to see that even in the data that she was finding, the findings are the same. It's always really helpful if what we're finding mirrors what our colleagues are finding as well. And so this gap, it's a roughly 20 to 25% gap, and it's seen across practice settings, private practice, hospital employment, academics, and women are less likely to receive compensation for call coverage, which compounds the annual gap. And these numbers are not improving year over year, emphasizing the need for targeted intervention. So taking a step back, if you speak to people who focus on disparities research, which I've been doing a lot of talking to people who focus on disparities research, they will tell you that there's rarely one cause for disparities. It's usually due to a convergence of several factors. So we know that women are underrepresented in leadership roles and at negotiation tables, which affects contract leverage. We know that women are less likely to be paid for call coverage or procedural add-ons. We know that referral patterns and gender within subspecialty concentrations can skew earning potential. And we know that institutional pay structures often reward metrics that are inadvertently disadvantaging women, such as high surgical volume over teaching and administrative work. So our data showed that this disparity isn't simply about outpatient billing patterns, but the differences appear to extend into access to higher reimbursing procedures, mentorship, sponsorship, other people sending you and referring you those more complicated procedures, and how opportunities are distributed. There may also be implicit bias influencing how work is assigned and compensated. So the next phase of our research is really focusing on identifying which of these factors are at play and which are measurable and potentially correctable. To help answer these questions and support the next phase of our research, I applied for and was awarded the Joan Giambalvo Fund for the Advancement of Women, which is a collaboration between the AMA and the Women's Physicians section of the AMA. And I think she's in the audience today, but it's always hard to tell in the Zoom quilt who's in the room. But Dr. Shannon Pryor, who's a mentor and friend, was the one who informed me of this grant opportunity. So I really owe her a tremendous thank you. So thank you, Dr. Pryor. And through this project, I'm working with a national cohort of female otolaryngologists in California, in Michigan, in Washington, D.C. And we're looking to explore specific contributions to this pay disparity. And our goal is to determine whether these factors can be corrected. And if so, how can we teach and advocate for equitable structures and behavioral billing patterns? And if we find that these factors aren't correctable through behavior modification, such as billing practices, then we hope our findings can really drive institutional and policy level change to address deeper systemic issues. So moving forward, and I couldn't agree more with what Dr. Matermask said, you know, there are several interventions that can make a tangible difference. And the number one factor is transparency in pay and call compensation. It's essential. I'm really unsure who gains among us by not being willing to be transparent in pay and compensation. So really opening the door for that conversation, encouraging your colleagues to talk about it, make it okay. After you share your number, be silent. Let the person you're talking to feel that awkwardness. Have them feel like it's important for them to share as well. Institutions should adopt standardized benchmarks for RVU expectations and account for academic and administrative contributions. That will really only come with advocacy. And mentorship and negotiation training for women can really improve individual outcomes, but it's institutional accountability that I think is most critical and really where you know, I'm hoping we can implement change, because equity has to be built into the system. It really can't be left to individual advocacy alone. So to close, we have to first recognize, as I'm sure all of us do, if we weren't convinced before, we're convinced now, that pay disparity persists across medical specialties. It's not just otolaryngology. And awareness of this disparity is not enough. We really must support ongoing data collection. I really commend MedChi for the data collection they've done so far, and transparent reporting of reimbursement payments. We have to push institutions to ensure equity and compensation in leadership and opportunity, and we have to empower female physicians through mentorship, through advocacy, through leadership development. As I once heard someone say, equity is not a favor, it's fairness. On that note, I'd really like to thank MedChi for inviting me to speak and talk about my research. And hopefully, I'll have more data to share and more results to share with positive results if we meet again. But I think we're opening up the floor for questions now or later. I'm not sure, but whenever that is, I really welcome any reflections or ideas for collaboration. And if we don't get a chance to talk tonight, you can feel free to reach out to me personally. Thank you guys so much.
Thank you so much, Dr. Rappaport. We did have a comment in the chat about don't use the word reimbursement, it's payment, and I agree with that view, and we should be mindful. But now we're going to move on to our third speaker.
I will say
Dr.
one thing. I will say one
Yeah.
thing that you're right. When we're advocating for what pay we're getting, it's important for that distinction. But I will say when you're talking about CMS data and when you look up the terminology within CMS, the term that they use is reimbursement. So with regard to
Okay,
research,
fair
you'll
enough.
probably hear us say reimbursement, but you're right.
Fair enough. Good
for telling
point.
that.
Thank you. Well,
Cameron,
so
do you think I could do some questions for the first two only because I'm trying to get my slides sent to Hamida because
okay, well, I don't know that any questions have come up. And Dr. Gebhardt, I can introduce you and
Hamida, can you check your email just to see if you got the slides? They would have just
sure.
come out. Thanks. There's 3 slides, I think.
so Dr. Roberta Gebhardt is a family physician. She was 2019-2020 AMWA, American Medical Women's Association National President. She was 2020 Physician Trust and Equity Board Member and Peer Supporter. And from 2018 to 2020, she served on Time's Up Healthcare Advisory Board. And I believe she's also founder and chair emeritus of AMWA's Gender Equity Task Force. I hope I got all of that right, Dr. Gebhardt. And thank you so much for joining us. I know you have your Gender Equity Task Force meeting tonight. Coming up in an hour and a half. So, Hamida, are you going to share her slides then?
Yes, I can share her slides. I'm just waiting for them to come over. Did you get my private chat, Dr. Gebhardt?
I'm looking for it, but I think that's where I sent them.
Should be HMANSARAY@medchi.org.
Yeah, I was trying to pull them up and I couldn't, so sorry about that.
I think already I feel a little more hopeful just because I feel like Dr. Rappaport, your research, I think it's reason for positive future. I mean, the first thing to solve a problem is to understand it. And it feels like instead of just wringing our hands, we're looking at details and possible solutions. But it is unnerving that the CMS payments somehow seem almost biased. I mean, obviously we're trying to understand. Forum Sangavi, did you want to ask your question?
I just I didn't really have a question, but I just wanted to say thank you so much for holding this event. I'm a new career physician. I'm a fellow at Georgetown currently and looking at positions, and I understood that there was a pay gap, but I feel I never really saw the data on it or in the literature, and it's very empowering to have that information, especially going into my career early in my career. So I just appreciate the empowerment. I appreciate the information, and I'm really grateful to be here today.
Well, thank you. I'm glad that you're here and all of our listeners. And I think nearer to the end, our last speaker, Mr. Kaufman, is going to give us some very specific information on how to improve our position when we sign on the dotted line. Are we getting closer, Dr. Gebhardt?
I'm just going to make one more try, and then I'm going to go ahead and get started. But all right.
You sent it to the email?
Yes.
And it's not coming through. Let me check my
And
junk
Dr.
mail.
Gebhardt, I completely sympathize and empathize, I assure you.
I
Some
just
of
want
this
my
technology is tough.
I just want my students to send it, so hopefully it'll get to you. So again, I'm Roberta Gebhardt. I'm a family medicine physician. I retired about 7 years ago and have made my my advocacy work for the end of life for me in gender equity. I've kind of I've done that all along my career, and I'm going to actually start out with my first negotiation, but really have put a lot of time and energy into this right now. So my first negotiation was when I was done with residency, and I was offered many different positions around the country. And one of them was a job with the Indian Health Service in Wolf Point, Montana. And I also was offered a job in Missouri with the National Service Corps, but I wanted to take the one in Montana. They were offering for me only to be a commissioned corps. I couldn't be a civil servant, and they wanted to pay me $50,000 a year. So now you know how old I am. and so and then the other job was going to pay me like 78. And so when I went to negotiate, when they made the offer, my response to the offer for Montana was, I will accept the position if I can work as a civil servant rather than a commissioned corps. If I could stay at Wolf Point instead of Poplar, and if it would qualify for my loan repayment. So those are the three things that I wanted, and I got all three. But literally, it changed the situation for everyone in the country that was a National Service Corps doc. And it turned out that my salary went from 50 to 100, not to 78, because that's how just what they ended up paying with overtime and stuff that year. And it actually, the other guy, one of the guys on the other side of the reservation, his salary went from 50 to 100 that year too, and he still doesn't know that was me. But it literally went, because they couldn't just do it for one person, so they had to do it for everybody. And they didn't want me to go to the National Service Corps. They wanted me to stay with Indian Health Service. So that was my first negotiation. I had a really good mentor in residency program, so I did not use, did I use an attorney for that one? I don't think I used an attorney for that. Yes, I did use an attorney for that one, actually. I did. It wasn't an attorney, it was a negotiator. So there are actually people out there that do negotiation for you. And this was a negotiator that I got through NARI, which is the National Association of Residents and Interns. I think it was free. I'm pretty sure at the time, if you were a NARI member, it was free. And so it worked out very well, doubled my salary, and it just worked out very well. So the second time was when I moved from Wolf Point, Montana to Ohio, and I was going to the National Service Corps. And when I got there, it was like, or when I was interviewing, it was pretty much, they couldn't quite get it right. They kept using my wrong name. They called me an MD instead of a DO. They called me Mrs. Gebhardt. It was just they just couldn't get it together. So I decided to use a negotiator, and I did, use a male negotiator, because I thought that would be more powerful for me. And he was able to negotiate me from a 4-day work week to a 5-day work week. And he was able to negotiate for instead of 4 weeks of time off, 6 weeks of time off. And he negotiated me from an extra 20,000 a year. So I felt that was very helpful for me. A lot of people criticized me because I had a male doing the negotiation, but the community I was going into, I was the first female physician, and they didn't have the concept of it. Like I said, the nurse pulled out a chair and said, "Here, have a seat, Mrs. Gebhardt," and I was just like, "And you're going to be my nurse?" So anyways, so that's the negotiation I did. It came out very well for me. I've done negotiations since then. I negotiated when I went to work for the VA. I took a hospitalist position with the VA, which is an hour and a half from here. And they were really, really, really pressuring me to take the job. I was not in a hurry to go, but they were really pressuring me a lot. So I ended up taking the job. But when I was doing the negotiation, I was told that there's absolutely no opportunity for more salary. That's the cap on the salary. And so I'm like, I believed him. And so when I got there, I found out that there was a fellow that was junior to me, that he had only 1 year of hospitalist experience. And I'd been doing it for like 18 years. I'd been working at 18 years as a hospitalist. And they had paid him $10,000 a year more than they were paying me. And I was actually really upset about it. And I actually turned in my resignation and left. I just thought it was very unfair. The issue has to be that if you're gonna, you have to be willing to walk. And I was willing to walk because I felt very strongly about it. I asked him ahead of time if he's gonna lie to me about this, who knows what else they're gonna lie to me about. And so I just left that job and came back to the Buffalo area and have been here ever since. So I went from Maine, which I went to medical school, to Montana, to Ohio, and then I've been in Western New York since then. I'm going to tell you about one negotiation and one unusual thing that happened. So the first is the unusual thing. I don't know if you know Linda Brodsky. She's an ENT doc. She actually, do you know her, Sarah? Or you know of her? So she actually helped co-founded the Gender Equity Task Force with me with AMWA. And her story was she was told that she wasn't chair material when she had brought up that she'd be interested in it. But she sat on the committee to help them find a new chair. And when she sat down and opened up the folder, she found out that she was making 20% of what the men were making. So she had, even though their salaries ended up being pretty close to the same, she had to do much more procedures to have an equal salary to them. So 20% of hers came from the university and 80% of it came from the procedures. And it was the exact opposite with the men. 20% of it came from they had to generate 20%, and the rest of it came from the university. And she actually filed a lawsuit against the state. And during that year, I think it was like $3 million that the state had to pay extra, just that whatever was left of that year, but changed the system so that as a woman physician, you couldn't be hired at a lower level. So you had to be actually, you couldn't just hire women as volunteer faculty and give the men positions. They had to be equal. And then she also filed a lawsuit against Kaleida, which is our local hospital, and won that as well. So her husband, before all this happened, said, well, you have a choice, because the lawsuit was very expensive. You have a choice between House of Martha's Vineyard or your lawsuit. And she went with the lawsuit. And then it turned out that she got a much nicer house in Martha's Vineyard because she had a lot more money. But anyways, I forget what the total amount that she got, but it was in millions for sure. And then another doc I was talking to, she was a urologist, and she had mentored this male all the way through medical school, through his residency, and when he was offered a position in the same department, she said, he said, hey, would you want to look at my calendar for me, or my schedule for me? I'm sorry, my contract for me. And so she looked, luckily he wasn't in the room with her. He sent it to her, because when she opened it up, she found out that he was being offered $175,000 a year, more than she was making. She was a full professor, had, tons of publications, just like Linda did. I think her CV was like 50 pages. But because he was a guy, he was getting offered 170, and of course there's negotiation beyond that. So he can negotiate up from there. So, when you're thinking about negotiating, one of the places I went to interview, which was the one that I chose, or that I chose the Montana one over, they offered us $50,000 a year when we went there to interview. And then I negotiated, and so I got up to like 78. My friend stayed in there and negotiated up to 130. And so if they're willing to give 130, why are they starting out at 50? And if you don't negotiate, you leave all that money at the table. So you can, if you don't feel comfortable negotiating yourself, you can find someone to negotiate for you. There are people that do that, but sometimes attorneys will do that for you, or sometimes they will go over your contract with you. You kind of make a decision about what you're going to negotiate for, and then they'll kind of talk you through it and how to do it. You know, or they can even write a letter on your behalf. You know, I will accept it under these circumstances. So those are the kind of, you know, things that happen. And I was asked to talk about resources. So my first recommendation is to join the American Medical Women's Association. I personally have been working for more than 20 years with people having issues at work or issues of negotiation. So that's the first thing. And also consider getting involved in our Gender Equity Task Force. We are doing wonderful things. We have a podcast now. We have a blog. We also offer, like the AMA does, a $10,000 a year research scholarship in Linda Brodsky's name. And we do that most years. We don't do it every single year. We do it most years, just like the AMA does it. Like they've been doing theirs for a long time. We've been only doing ours for like 3 years. So we try and do it every year if we can. They used to do 2. I think they're down to 1 now. But anyways, you know, there's lots of things that we do that we think are moving the needle. We've done several publications that have been, that have gone over very well. And so I suggest that, you know, if you're going to join AMWA. The other thing about AMWA, which I forgot to mention, is if you are first of all, if you have 5 people or more, you can use the group code there, which is group, and you can get, I think it's like 20 or 25% discount as a group if you have 5 people join. And also if you're an ACP member, you get like 20% off. So, I'm sorry, you don't pay anything. If you're an ACP member, you don't pay anything, but you have an affiliate membership. So the only thing you can't do is you can't vote or hold office. So if you like it, you know, you're not paying for it. You have all the other benefits. But if you like it, you can just pay, I think it's like $50 to increase it to just a full membership. There are 2 books, and I was hoping to have them here to show to you, but I don't. One of them is Women Don't Ask, and the other one is Ask for It. They're both written by Linda Babcock and Sarah Lashover. The second book by Sarah Lashover, the second book by them is Ask for It. And that actually has a boot camp in it. And that's what I found to be the most helpful. So our medical students had Sarah speaking at one of our meetings in Washington, D.C. And when she was done speaking, you know, I raised my hand very quickly. I said, I'm going to do my first negotiation here. Can you sign my book? Because I'm supposed to be meeting over in the other building with the Surgeon General for pictures right now. And I said, and can you also give me your email? So she did that, and I ran over to the building, and it worked out very well. But you negotiate for like little things is so important. So that's what the negotiation boot camp talks about, like negotiating for things that don't matter. Like when I was buying some roses one time, I paid for the roses. I said, "Is there any way you can give me, you know, a bottle, you know, whatever, 6 bottles of water, because I'm giving these to people?" And they literally just gave me 6 bottles of water. They were like $2 or $2.50, $2 or $2.50 a piece, and it was basically the same price as the roses were. So it worked out, you know, very well for me. And you know, what's the worst they can say? No, okay, no problem. I negotiated one time. We went down to Florida, and I negotiated $825 off of our rental car, and it took me over an hour. And my family was like really upset with me because they were sitting in the airport instead of playing around in Florida for the hour. I said, "Look, we have an extra $825 to spend on our vacation." So, you know, it was $875 an hour that I got paid for that. So, so just negotiating for little things is really, really important. But whatever you do, negotiate. AUW, which is the Association of University Women, American Association of University Women. Any woman can join that. If you have, I think it's at least a bachelor's degree, but I think they're going down to an associate's degree, and they do fabulous training for women specifically on teaching them how to negotiate, which is an amazing program that they do. They can also come to your institution or your group and do it for you. I mean, there's a charge to it, but it's not very much. But, you know, learning how to negotiate is really, really important. The next one is, I know somebody just talked about, being a fellow and looking for jobs. Get an attorney to review all of your contracts. I cannot tell you enough. And anytime anybody asks me, this is what happened at work, what should I do? I say, go back to your contract and talk to the attorney that negotiated it for you, because that's a person that knows you already. So if you've ever tried to get a hold of an attorney, it's like, oh yeah, I can see you in a month, but this is somebody you've already worked with. They know you for that reason. And they've hopefully protected you, help you to protect yourself. So what I have here is, like, for an example, every time I negotiate a contract, I can't believe the number of people that negotiate a contract and it says you have to give them, 90 days notice, but if they get rid of you, they don't have to give you any notice. And that's what the contract is. And it's like, well, why would you ever sign that contract? So I always negotiate for 4 months, and it's helped me many times. So I was doing it for 4 months. So if I'm going to leave my position, I'm going to give you 4 months notice. But if you decide you don't want me here for whatever reason, you're going to have to give me 4 months or 4 months notice. And it works out really well because it gives you 4 months to kind of figure out what you're going to do, take a vacation, relax. I mean, it's just really super. Everybody, please, please, please get out and vote. I cannot, what we're experiencing right now with regards to losing women's rights. Every single woman needs to get out there and vote. And things that we advocate for, pay transparency, equitable pay, support for other, and also equitable pay. And then that's also supposed to be, the last one is to support other women. The number of people that I see that I've seen like terminated or whatever, and everyone kind of looks at them like, oh, they did something wrong. 90% of the time, they just piss somebody off. And it could be that they were advocating for themselves. It could be that they were advocating for somebody else. I do know during COVID, most women in Buffalo were the ones that they let go during COVID. The men kept their jobs because most of them were in leadership, and so all the leaders stayed working. And so just you want to increase the transparency and make it fair that everybody has the opportunity to be paid. And it's not just money, it's time, it's resources. You can negotiate for anything, honestly. You can negotiate for them to pay your moving expenses or get you a car. You can negotiate for anything. And depending on how much they want you, the fellow that was negotiating my Ohio contract says, these people really want you. Like every single thing I've asked for, they've given me for you. So, that actually kind of gives you an idea on what kind of place you're coming to. Are you going to a place that's going to treat you well and treat you with respect? And then the other thing is just kind of random that I want to throw out there is if you go to interview in places, when you walk into the place, you always look to see where they put the doctors and where the administrator is. And so very often, especially in these small places, the administrator has this luxurious office, and they have a table around where they have 5 doctors share a table for their workspace. And so in those places you're just not going to be respected. They just don't respect you as a physician. If they're going to give you space, you deserve at least as much as the administrator has. So I would just always make that kind of a red flag. So that's all I have. Thank you very much for inviting me, Carolyn. I really appreciate it. I've loved speaking with all of you. And I was supposed to have I'm going to actually put my information in the chat. There's supposed to be another slide with that on it, but it seems to have gotten lost in the shuffle. So I'll have my phone number down. I always tell people you can email me first. If I don't answer, then send me a text. And if I don't answer that, then call me. And it is my cell phone number that I'm going to put. So thank you.
Thank you so much, Dr. Gebhardt. It sounds like you have we should bring you along to negotiate for us, but it sounds like you've been very successful. But that brings us to our attorney, who's going to share tips exactly on contracting and negotiations. Steve Kaufman's a Baltimore lawyer who lectures nationally to doctors about employment contracts and negotiation skills. He's helped thousands of doctors negotiate employment contracts, partnership agreements, and practice purchases and sales. So thank you for joining us, Mr. Kaufman.
Well, thank you very much. Let me see if I can get my slides up here. Okay. See how we do. How's that? Everybody seeing them? All right, here we go.
Not
Okay,
yet.
Oh, we can't
Wait,
see them yet.
not
you're
yet.
not seeing them yet. Okay.
No.
Same issue as last time. Let's see why are they not here? Goodness. There we go. Now do you see them?
Yes. Yes.
Excellent. All right. So here we go. All right. Well, this a little bit more about me. I have helped doctors all over the country, whether you're coming out of residency or fellowship. I've helped negotiate contracts, all 50 states, most U.S. territories. I'm also a union negotiator for one of the bigger physician unions in the United States. So I go against the institution on behalf of all of you together. And then when I come home at night, I can do it some more because my wife's a physician who runs her own practice. So,
Mr. Kaufman, I just
Yes,
want to let
ma'am.
you know you're in presenter mode. We can see your
You can see everything.
note slide,
Why is it doing that? Thank you. Let's see
which
if we
is
can.
fine. I
No,
know that
no.
you
Here we go.
practiced before.
How's that?
There, you got it
Perfect.
now. Thank you, Dr. Moddermast. Yeah, I
Yeah,
wasn't going to
thank
tell
you.
him, but you fixed it.
Excellent. Thank you. All right. So what we want to do is close the pay gap here. I want to start with a little story. This is, I got to look over here. Pardon me if I'm looking because it's the wrong place, but this is Claudia Golden. She is the first woman to be a tenured professor in the economics department at Harvard, where she studies wage disparity. Why are women paid less than men? And she's so good at it, she won a Nobel Prize in economics for her studies. I listened to her give a lecture, and she told a story on herself about being hired by a Fortune 500 company as a consultant. They were worried that they had structural wage disparity and they wanted somebody to look at it. So they hired her and two men to look into it as a committee. They went, they did their study, they reached their conclusions, and they determined that the company was not discriminating against women, that systemically they were doing fine. And then Dr. Golden found out that she was paid $2,000 for the job because that's what she was offered and she took it. And the men each made $5,000. And the reason for that was she didn't check what her value was. She forgot to do that. And she didn't negotiate, and they did. So when you're taking a job or you're renegotiating a job, make sure you know your value, right? You can look at MGMA studies for it's not just money. You can see all kinds of things. How hard people are work, RVUs, there's all kinds of data. You can, at MedChi, salary survey is great, and talk to your colleagues about that sort of stuff. Let's see. Now, you got to negotiate, but you need to know your rights, right? And you actually have some pretty solid rights. Women are entitled to equal pay for equal work. Period. End of story. It's protected federally, right? The Equal Pay Act. Let me see if I can. What is going on here? There we go. Okay. Sorry about that. The Equal Pay Act says that, look, if you're doing the same job, substantially the same job, you need to be paid the same. And it's not your job title that determines whether your jobs are the same. So if you're both in an outpatient setting and you're doing the same job and you're paid differently, there better be a really good reason for it, particularly in Maryland, because we've got a really good Equal Pay Act here in Maryland where you can't be discriminated against in rate of pay. So if you're being paid in RVUs, relative value units, right? And the guy is making $50 an RVU and you're making $35 an RVU for the exact same work, somebody's breaking the law, right? So it doesn't matter that you might make less money. So if, given what we know, right, women spend a little more time with patients, maybe they see fewer patients. That shouldn't matter with the rate at which you're paid for RVUs. If you work 4 days a week and a guy works 5, and the rate should be the same. I don't know, you make $100,000, that's $20,000 a day. Somebody working 4 days should make $80,000. You shouldn't make less. And it's also not just discrimination in wages. I have had countless women come to me and tell me that there are, when patients call in, they're scheduled, they're referred the inferior work, at least from a value standpoint. They're given that MA who nobody likes and we got to dump somewhere. The equipment isn't as nice. The offices aren't as nice. Even access to specialists. I can tell a story about a local hospital that brought in a world famous speaker, and all the men sat at the table with the speaker and all the women were shunted off to the side as if it were kids' tables. So there's a lot going on here. And it's also promotion, right? You should have the same opportunity at promotion as everybody else. The guy shouldn't be told about it first. There shouldn't be fake interviews. You have equal rights when it comes to these things. Another real important thing is pay secrecy. You will see most hospitals and a lot of private practices put into their contracts that you're not allowed to talk about your wages. You're not allowed to talk about what's in your contract. The vast majority of them do it. It's against the law because that's the way you discriminate against women and minorities, right? If the guy is making a lot of money and he's not allowed to tell the women how much she's making and she's not allowed to talk about how much she's making, you don't find out that you're making less money than the guys. The minority, if you're a minority, you don't find out that you're making less money than the white guy. It's against the law, and it's also very hard to unionize if you can't talk to your coworkers about your conditions of employment. So when you see that in employment contracts, first know it's not enforceable. They can't fire you for doing that, even though they claim they can. I suppose they can, but then they'll get sued and you won't have to work anymore, which would be nice. But they're not allowed to do it. And when you see it in their contract, say to yourself, what kind of culture is going on here that they're trying to hide their pay scale? I will also add, somebody else talked about it. I forget which of the prior speakers, but the idea of wage range, knowing what is paid. In Maryland, employers are required to give you the wage range before they make an offer to you about pay. So there's a bunch of ways they're required to post it, but even if you don't see it posted somewhere, you just ask them and they must tell you this is the wage range for this job. And I strongly suggest always doing that. Don't fall for the, hey, how much are you looking for? Make them tell you how much they pay first. Okay? Now, they'll play games like that, but they play a lot of games. Employers play a lot of games, and the two biggest ones I see is they're going to tell you their contract is standard. I would be shocked if everybody on this, if most everybody on this call who's had a contract, who's negotiated it, wasn't told it. Hey, it's fair. It's the same for everybody. It's almost a universal thing to tell everybody it's standard. We can't change it. Well, it's my attitude on that. There is no such thing as a national standard. There's no regional standard. There's no local standard. There isn't even a standard within a particular institution. It's always amazing. You'll look at a contract that they tell you can't be changed, and you can look at the revision date in the bottom right corner of the first page. Somebody changed it. I have seen contracts, local hospitals, national, other systems around the country, where their legal departments lock the documents so that the department chairman or the negotiator can't change terms, but then they leave terms that can be changed. And you can see it because they screw it up with their macros. So I can see it where they let them negotiate pay, signing bonuses, moving expenses, retention bonuses, how hard you work. Lots of things are negotiable. You just have to do it, and they're not telling you the truth. When they say we can't change it, what they really mean is we don't want to change it. So you got to push them. I mean, look, I doubt there's anybody on this call who thinks that they're standard. Well, if you're not standard, why would you sign a standard contract, right? The second big game that employers play is related to standard, and it's the trust me game. And I'm willing to bet most everybody's heard this one too. What happens is you get a contract and it says that let me back up. You were told that you're going to work at the office in Rockville. You're going to work for a multi-office practice. You're going to work for a hospital system. They tell you, yeah, you're going to work in our Rockville office, and you're going to work 4 days a week. And then the contract comes in and it says, yeah, initially you work in Rockville, but then we can move you anywhere you want, right? That means they can change it on you, right? And if you trust them, they're going to forget. Maybe honestly, maybe conveniently, or maybe the person you spoke to leaves, and now you have a piece of paper that says that they can move you anytime they want, and you say, yeah, but that boss who left told me you would never do it. That doesn't work. As a lawyer, I would say that when there is a written contract, an oral agreement on the side isn't worth the paper it's written on. You do not want to trust them, right? Now, what you need to do, and I'm going to be echoing particularly what Dr. Gebhardt was saying, is you got to negotiate. Everything is negotiable, all of it. But what I find is that a lot of times people don't negotiate, partly because maybe they think it's standard and it's not negotiable. But often you don't negotiate because you're afraid to negotiate for some reason or another. Some doctors are conflict adverse. That's why you're doctors instead of being lawyers, right? So you don't want to directly challenge somebody. And then there's always the fear of, I'm going to look foolish because I don't know what I'm doing, or they're going to steamroll me, or I'm going to look greedy or needy and I'm afraid I'm going to lose the job, right? Or particularly for you guys, I don't want to be labeled a bitch, right? Because I'm assertive. I'm concerned about that. Well, when that goes through your head, do your best to ignore it, because first off, you're not going to lose the job by negotiating. You're going to end up, as I'll show you in a second, you're going to end up with something good. And if you're uncomfortable, look, I teach negotiation nationally. We don't have time for that today, but you can learn to become a better negotiator. And if it's just not you and you don't want to do it, look, I could do my own taxes. I hire an accountant, right? So if you don't want to do it, get a lawyer. Call me, or if you already have a lawyer, get a lawyer, because it's business to us. When I deal with the other lawyer, nobody gets insulted. Nobody's mad at anybody. It's an economic discussion. We might have reasons for it. I'm trying to convince them to convince the boss to give you what you want, but it's not like this. And it's just much easier lawyer to lawyer. Do it all the time. But you got to negotiate. And there's 3 powerful reasons to negotiate, right? First reason is you will get more stuff. Now, I don't know what the stuff is. Maybe it's more pay. Maybe it's a signing bonus, more vacation. Maybe you're harder to fire. Maybe if you're subject to a non-compete, we'll come to that. You get a lesser one. But you will get something, because employers leave themselves wiggle room. It's like anything else. They're not going to make their best offer to you. They're going to offer you something less than they're willing to pay, or whatever the benefits are. They're going to offer less because they know that a lot of people are going to negotiate and they want some room so they can be good guys and they can give up something. And so they leave themselves some room. So the real rule here is, if you don't ask, you don't get. So you have to ask. All right. It's rule 1. That's the first reason to negotiate. The second reason to negotiate, I used to have Will Smith here, by the way, but then he did that going like this, but then he did that Oscar thing. So second one is, you're going to learn more about your job, because you can use your contract as a framework to discuss what your day-to-day life is going to be like. Take that example I gave before of the doctor this is a true story. I had a doctor who was joining a multi-office practice. She was promised that she would work on the north side of town. Contract came in. It said that they could move her whenever they want. We had a discussion that was a lot like a vice presidential debate. They kept changing the subject because they didn't like the question, right? But you keep going and you keep pushing. And eventually what they admitted was that they had somebody leaving from their office on the other side of town where my client did not want to work for a variety of reasons. And they wanted to leave open to move her there because they thought she would be a good fit. She didn't take the job. If she hadn't had the discussion, she would have trusted them. You're going to work on the north side. Don't worry about it. She would have signed a contract that allowed her to move, and they would have moved her, right? Stories like that are legion, right? You want to have a discussion about what the job is going to look like so you can flush out the differences between what they tell you and what the contract says, and why are they different? Because they always are. I've done 5,000 contracts. I've never seen one that matched the conversation that the doctor had with the prospective employer, ever. Right? That's the second reason to negotiate. You learn more about your job. The third reason to negotiate, and if there's any pediatricians here, I hope you went ooh, ah, something like that. Otherwise, I worry about your compassion levels. But number three is you're going to learn about your employer. Negotiation reveals character. You know, sometimes you'll negotiate and they're good guys about it. They listen to you. They listen to your concerns. They try and accommodate you. They look for win-wins, and they're really reasonable about it. And sometimes you get people who are just flat out bullies, or particularly when you're negotiating with a man, flat out bullies, or you get patronized. The worst patronization story I've ever had, this is going to be a direct quote. I don't need to read it to know it. I had a female doctor who was offered a job, a male boss to negotiate with, and my client sent an email with the things she was worried about, her concerns, things she wanted to change, things she wanted to talk about, things she wanted to discuss. And it was a really good email. It was professionally written. And I know this because I ghostwrote it for her, right? And the response came back to this email, direct quote, "You're so cute." No, really, you're so cute. Actually said it twice. You're so cute. Don't worry about this. It'll be okay. Now, I don't think you can run away from a guy like that fast enough. And she did. But if you don't negotiate, you don't find out that you're going to work for a jackass until you've given up your other job opportunities and maybe you're saddled with a non-compete that makes it hard to take those other opportunities, even if they're still available. You gotta negotiate. It reveals character. And here's your 3 reasons to negotiate. You'll get more stuff, you'll understand what you're getting into better, and you'll get to assess their character. Now, there is one thing I want to address substantively here about contracts, and that's non-competes, because in Maryland, on July 1 of this year, if you make less than $350,000 a year, non-competes are no longer legal in this state. If you signed a contract after July 1, if you signed it 2 years ago and it has a non-compete in it, that's still valid, at least until some court says it isn't, right? If you make more than $350,000 a year, then they're limited to a 10-mile circle for a non-compete, maximum 10 miles around one workplace. So they can't put a circle around 5 offices where you work. They're going to pick one primary workplace. So if you are mid-career or you're renegotiating a contract, right? If you're just getting a new one now in Maryland, it won't have a non-compete. But if you're renegotiating and you have a non-compete, I don't think there's anything you can do to put yourself in a more powerful position than to get rid of the non-compete that's in your contract. You go to your boss and you say, "This isn't fair. That new doctor you just hired doesn't have a non-compete and I do, and I've been working here for 10 years. That's not fair. I want it equalized with what they have," and get it taken out of your contract. Because when you get rid of the non-compete, you potentially solve a lot of problems. Because when you have a non-compete, you can be abused at work, right? They're not going to give you the big raise. They're going to give you the lousy call schedule. They can make your life miserable. And if you complain, they can basically say, "What are you going to do about it?" You have a non-compete that throws you out of the state or throws you out of the county. What are you going to do? Pick up and move? You're not going to do it. But if you get rid of the non-compete, now you can take a job across the street for more money. right? Now you got some real leverage when you go in to renegotiate because you can go across the street. And if they abuse you, they know you can walk out on them relatively easy. So it'll take an employer that might be abusive and make them calm down a little bit because they got to worry you're going to cut out on them. So the non-compete, to me, if you can get rid of the non-compete in the contract, it solves a lot of ills. All right, now I want to finish with a story. For those of you who haven't seen it, there was a movie that Sony Pictures put out called The Interview. It was a satire of North Korea and its fearless leader. And the fearless leader did not like the movie. So he hacked, or he had his people hack Sony's emails. And they were released to the public. And when they did that, Jennifer Lawrence, who was at the time probably the biggest star in Hollywood, found out that she was making less money than the guys she was starring in the movies with, who were not nearly the box office draws that she was. And I got to apologize because I got to lean over here because of that other problem I had, but I want to read you what Lawrence had to say. Lawrence blames herself for not fighting harder for better pay, but admits that as a woman, she felt under pressure not to be labeled difficult or spoiled. When the Sony hack happened, and I found out how much less I was being paid than the lucky people with dicks, it's her, not me, I didn't get mad at Sony. I got mad at myself. Jeremy Renner, Christian Bale, and Bradley Cooper fought and succeeded in negotiating powerful deals for themselves. If anything, I'm sure they were commended for being fierce and tactical while I was busy worrying about coming across as a brat not getting my fair share. But she warns she's not going to let gender stereotypes hold her back in the future. I'm over trying. Oh, I lost the quote. I'm over. Where did it go? Oh no. She was like, I'm over trying to find the adorable way to state my opinion and still be likable. F that, she added. And that's my attitude towards it. F that. Get out there and negotiate. If you're worried that you're going to get perceived as a bitch, get some lessons or get some help, but don't be afraid to do it, because although there are a lot of reasons why women make less money than men, there's no excuse for not negotiating and getting more, because you almost always will. And with that, I think that's me. If anybody's trying to find me, that's my V card. If you take a picture of that, you'll be good. And I'm done. Thank you, gang. Appreciate it.
Thank you so much, Mr. Kaufman. That was very enlightening and a great way to wrap up our 4 speakers tonight. Now, I think at this point we can stop the recording, Hamida. And I wonder